Good morning, everyone, and welcome to our Grand Rounds today. Our speaker is Dr. Tina R. Goldstein. Tina Goldstein, PhD, is a licensed psychologist and associate professor of psychiatry and psychology at the University of Pittsburgh, where she also serves as the director of psychotherapy training in pediatric mood disorders, director of the NIMH-funded postdoctoral training program for clinical psychologists, co-director of the predoctoral clinical psychology internship program, and co-director of the Services for Teens at Risk Center. Dr. Goldstein's clinical and research interests focus on understanding the etiology and treatment for youth with and at risk for mood disorders and suicide. Her work aims to develop improved prevention and intervention strategies for this population, informed by an enhanced understanding of the relationship between biological and psychosocial determinants of mood disorder and suicide. Dr. Goldstein's research program is supported by grant funding from federal and private foundations, including the National Institute of Mental Health and the American Foundation for Suicide Prevention. She's the author of over 100 peer-reviewed manuscripts and book chapters on the topics of suicidality and mood disorders in youth, and is co-author of a book on the treatment of depressed and suicidal youth. Her contributions to the field have been recognized with numerous awards, including the Clerman Young Investigator Award from the Depression and Bipolar Support Alliance and the Presidential Early Career Award for Scientists and Engineers. Please join me in welcoming Dr. Goldstein.
Thank you so much for that really kind introduction, Molly. And thank you all for being here at this early hour. I'm really excited to be sharing some of our work with you and certainly to have some discussion later on. So I'm going to go ahead and share my screen here. All right. So this morning I'm going to be talking about enhancing outcomes for youth with and at risk for bipolar disorder and suicide. We'll also be talking some about unipolar depression. So first, these are my disclosures. Primarily, I receive research funding from numerous agencies. I'm an employee of the University of Pittsburgh, and I receive royalties from Guilford Press. So just to give you some background about the data and clinical experiences that I'm going to be talking about today, as some of you likely already know, I have the good fortune to be affiliated with two specialty clinics here at the University of Pittsburgh at Western Psychiatric Hospital. The first is the Services for Teens at Risk Center, led by Dr. David Brent, and the second is the Child and Adolescent Bipolar Spectrum Services Clinic, led by Boris Bermaher, both of whom have been really critical mentors and teachers in my own career. And so in both of these clinics, these are multidisciplinary research teams. They're also open clinics where, as many of you know, we assess and treat over 800 youth per year between the ages of 6 and 18 plus with mood disorders and at risk for mood disorders. We provide a range of services, including intensive evaluation, medication management, individual and family therapy, and we have an intensive outpatient program. And so certainly without these two clinical research programs, none of the work that I'm going to be talking about today would be possible. And these are enormous multidisciplinary teams of really skilled and devoted individuals. So my objectives for our time together today are first to give some background on early onset bipolar disorder and suicide risk, then to talk about clinical staging models as an approach to treatment, as well as risk prediction for mapping treatment. And then I'm going to talk just a little bit about some work that we've done in psychotherapy specific to these populations. So let's start with early onset bipolar disorder and suicide risk. So about 20 years ago, we got a lot of attention in the field about the focus on pediatric bipolar disorder. And this was both in the scientific community, but also in the lay community. Some of you may have seen these very popular covers of different magazines focusing on the epidemic, so to speak, of bipolar disorder in youth. So much so that there were some papers coming out at that time that indicated that potentially rates of early onset bipolar disorder were increasing up to 45-fold. And so much so that there had become this general belief that there was some epidemic of bipolar disorder in youth. And although there's been tons of research over the last 20 years to clearly indicate that bipolar disorder in youth is indeed a very serious and concerning illness that is a valid diagnosis in youth, by no means actually have there been such gross increases in actual cases of bipolar disorder in youth. And so you can see in red here, I indicate that per the data, there actually is no epidemic of pediatric bipolar disorder. Although it's certainly true that in the clinical community, we have seen increased rates of both overdiagnosis and underdiagnosis. And so in this slide, what you can see is some data from the Oregon Adolescent Depression Project back in the 90s, as compared to the National Comorbidity Survey replication in 2009. And so these are large epidemiological data sets in which they very carefully apply DSM criteria to diagnose bipolar disorder and other disorders in youth. And so what you can see here is the rates of bipolar 1 disorder in the light blue and bipolar spectrum disorders that includes bipolar 1, 2, and per DSM-5, other specified, per DSM-4, not otherwise specified bipolar disorders. And so I think the really critical take-home message here is that when we carefully apply DSM criteria to the diagnosis of bipolar disorder in youth, there's actually been a very insignificant increase in the number of youth who meet criteria for bipolar spectrum disorders. And so many of the papers that got so much attention about 20 years ago for this gross increase in diagnoses were primarily from medical records. And as I indicated, those in general are based on clinical impressions, potentially in an emergency room setting or a very brief evaluation. And so our take-home message here is the critical nature of applying DSM criteria very carefully to diagnose youth with bipolar disorder. And certainly I'm here to tell you from doing this for 20 years, it is no small feat. It is certainly very challenging, which I think also explains all of the controversy. So why should we even be interested in early onset bipolar disorder? Relatively speaking, it's a less common disorder than many other psychiatric disorders in childhood. Well, there are a number of reasons. The first is there's gross increased risk for negative outcomes among youth with bipolar disorder. They're at increased risk for substance use, other high-risk behaviors like sexually transmitted diseases, incarceration. It's also a highly recurrent illness. For a while, folks were indicating that perhaps youth with bipolar disorder would outgrow their illness, or that it would turn into some other psychiatric disorder in adulthood. But indeed, data over the last 20 years clearly indicate that the vast majority of youth do relapse with symptoms of bipolar disorder over 4-year follow-up. And we have lots of data to indicate that the earlier their illness onsets, actually the worse course of illness into adulthood. So early onset bipolar disorder is a marker or flag, so to speak, for a more severe course of bipolar disorder into adulthood for some youth. The illness is also associated with substantial psychosocial impairment, and this is across domains of functioning, including social functioning, academic, and familial functioning. So there's a significant impact on these youths and families' lives. There's also a huge economic burden. Of all psychiatric disorders, bipolar disorders in youth is among the most expensive to treat throughout childhood and into young adulthood, primarily driven by high rates of emergency services and inpatient hospitalization. And so I argue that we really have this window of opportunity early on in the development and onset of the illness to try and improve and change the course of illness over time. Another area where I've been particularly focused is on suicide prevention in this population. Sadly, currently, suicide is the second leading cause of death among young people in the United States, and certainly is becoming a public health crisis in the face of the pandemic. And so critically, this is an area of focus. We also know that among all psychiatric disorders in youth, bipolar disorder is associated with exorbitantly high risk for suicidal behavior, death by suicide, and suicidal ideation. What you can see here are some data from Pete Lewinson and his group back in the 90s, showing in red bars youth with bipolar disorder diagnosed using DSM criteria, and the blue bars, youth with major depression. And so generally speaking, we tend to think about major depression in youth being associated with suicidality. And yet what these data indicate very, very clearly is that youth with bipolar disorder actually have higher rates of suicidal ideation and suicide attempt. So much so that 3/4 of youth with bipolar disorder in the sample endorsed lifetime history of suicidal ideation, and almost half endorsed lifetime history of suicidal behavior. Some studies early on from one of my mentors, Dr. Brent, indicate that of all psychiatric disorders in youth, bipolar disorder actually imparts the greatest risk for death by suicide as well. So this was from a psychological autopsy study where they interviewed families of youth who had died by suicide and did diagnosis, kind of looking backwards based on the reports of their family members. And so I was also really curious to document risk for suicidal ideation and behavior among youth with bipolar disorder carefully diagnosed. And so these are some data from a longitudinal naturalistic study of over 400 youth diagnosed carefully with bipolar disorder. On average, the youth were about 12 and a half years old at this cross-sectional analysis. So it's really critical to remember that these youth weren't even through the highest risk period for suicidal ideation and behavior. And so what you can see here is that about 1/3 of the sample endorsed a lifetime suicide attempt at study intake. So these are all youth carefully diagnosed with bipolar disorder, about 12 and a half years old. And furthermore, we can look at this area highlighted in red, showing the seriousness of these suicide attempts. And so black indicating that these were extreme suicide attempts, dark gray indicating severe. So there was every expectation that these youth would actually die as a result of their suicidal behavior. So these really highlight the exorbitant risk for suicidal behavior among youth with bipolar disorder. We then used this same sample followed longitudinally. So we assessed these youth on average about every 9 months over a period of 5 years. And what we found is that about 20% of the sample of youth with bipolar disorder attempted suicide over the 5-year period. And over 40% of the attempters made more than one suicide attempt over this period of follow-up. And really critically for me is trying to identify among youth with bipolar disorder, we know the whole sample is at high risk for suicidal behavior. How can we know what are some of the near-term predictors of suicidal behavior? And so what we did in this study was look over follow-up and identify the period at which youth made a suicide attempt, indicated here with this red star. Then we looked in the 8 weeks immediately preceding the suicidal behavior to try and figure out what was different during those 8 weeks as compared to all of the other 8 weeks over follow-up. And so what we found was largely not surprising. The first was that those 8 weeks immediately preceding the suicide attempt were characterized by greater weeks spent with full threshold DSM depression. So no big surprise, depression is associated with suicidal behavior. Those 8 weeks were also characterized by greater weeks spent abusing substances. Again, we know from the adult literature and the unipolar depression literature that suicidal behavior is associated with substance use. One thing that was particularly surprising for us is that we actually found that those 8 weeks immediately preceding the suicidal behavior were actually characterized by greater psychosocial service use. So these youth were actually getting more services in the 8 weeks right before their suicide attempt than they were during all of the other 8-week periods over follow-up. And so this was really a head scratcher to us. And so the way that we've come to interpret and try to understand this, and I'd be really interested in others' thoughts as well, is that the good news, and there's good news and bad news. The good news is that the youth themselves and their providers were recognizing that these youth were entering a high-risk period. There was response in terms of the psychosocial interventions. They were stepping up care from outpatient to intensive outpatient, partial programs, and even hospitalization. I think the bad news take-home message here is that, unfortunately, these intensive services were not substantially improving risk for suicide attempt as far as we know. And certainly there's still a high risk for suicide attempt, even in the face of receiving these more intense services. So what does all of this mean for assessment and treatment? We know that the treatment guidelines for children and adolescents with bipolar disorder indicate that optimal treatment includes both medication and psychotherapy for the optimal treatment of pediatric bipolar disorder. And it's really critical to me that I clearly communicate that, that while there are several different treatments that have an evidence base in terms of psychosocial treatments for early onset bipolar disorder, all of them probably have more in common than they have different from one another. So there are really these evidence-based core components of effective treatment for pediatric bipolar disorder. So likely it's a little bit less about DBT versus CBT versus IPT, which I'll talk a little bit more about later, but rather really recognizing that optimal treatment includes some of these core components. The first being psychoeducation about bipolar disorder and specific to early onset bipolar disorder, the nature of it, how people develop bipolar disorder, expectations for course and outcome. We also teach families mood monitoring to help patients and families recognize their symptoms, recognize high-risk periods, and learn skills for managing their own symptoms. We also aim to enhance family and social functioning. We know that these early onset bipolar disorders, among many other psychiatric disorders, have an amazingly large impact on families and youth. We also work on relapse prevention to help youth and families feel that they have more control over their illness. We know that these disorders are multiply determined. And so in terms of clinical staging models, I've been really drawn to these specific models that have been applied across psychiatric and other medical conditions. And so these are really ways of thinking about the development and progression of illnesses over time, and helping us think about how do we map on treatments to the specific stages of disorder. And so what we see here is the specific stages of disorder going from a 0, which is high risk and asymptomatic. So these are youth who we know have some predisposition for bipolar disorder. We'll talk a little bit more about that momentarily. But they're not yet exhibiting any symptoms. So these are youth for whom prevention could be indicated. Moving on to level 1, which is high risk, where youth are displaying non-specific or subthreshold symptoms, but don't meet full criteria for any specific diagnosis. Moving on to threshold symptoms at level 2, where they are receiving diagnoses of a variety of psychiatric disorders, because we know that these illnesses tend to unfold over time. And then, of course, stages 3 and 4, where youth are having recurrent illness with severe functional impairment. And the idea behind these clinical staging models is that where we are able, we try to intervene earlier in the progression of illness to try and enhance outcomes, but also that we match the intervention to the level of illness staging, such that interventions at level 0 tend to be less intense, potentially less costly, and they increase over time. So how do we map on our treatments to the appropriate individuals. Which treatment is right for whom and when? I think that's really the critical question facing psychiatry, and particularly in terms of treatment. And so in general, in psychiatry, we've been really good at identifying group level risk factors. So these are useful for identifying preventable and modifiable risk factors and specific treatment targets. And so these group level risk factors are really necessary. We need to know, on average, at the group level, who is most likely, for example, to develop bipolar disorder or to engage in suicidal behavior. So for example, we know that individuals with depression are at increased risk for suicidal behavior. Individuals with bipolar disorder are at increased risk. But the problem is that these group level risk factors really don't tell us anything at the person level. What we really need to know as providers is, with this patient sitting in front of me in this moment, what is this individual's risk for developing bipolar disorder or attempting suicide? And so currently we do tend to use a variety of tools, right? We have self-report, we have clinical evaluations, but unfortunately, data indicate that these tools are actually not much better than chance at predicting outcomes, and particularly at predicting suicidal behavior. And sadly, nor is our clinical judgment. And so that's not necessarily to undermine our clinical judgment. All of this is critical. And what it tells us is that we need additional tools to be able to improve prediction and improve mapping of treatments and interventions. Given this patient in front of me, at this moment in time, what is the optimal treatment for them that they are most likely to gain benefit from, knowing that that potentially could change in a week or a month or a year. And so our group has been really drawn to what's called risk calculators as a tool for improving risk prediction. And so what are risk calculators? They're basically just clinical tools that take these group level risk factors. For example, on average, people with bipolar disorder are at higher risk for suicidal behavior. And then they take some optimally identified set of risk factors that we put together to try and predict an estimated person level risk. So based on an individual's level of risk on these various variables at this moment in time, what do we know about their risk for a specific outcome? It could be any outcome at this particular moment. And so risk calculators are not new in medicine. Many of us are probably familiar with a variety of risk calculators widely used in medicine. These include very reliable risk calculators for stroke and heart disease and even cancer. More recently, risk calculators have been applied in psychiatry to other disorders like early onset psychosis and ADHD, but they've been less widely applied in the area of mood disorders. So we've been really fortunate because we have two very large data sets that are longitudinal that have enabled us to build some risk calculators to better predict outcomes for youth with mood disorders. The first study is the Bipolar Offspring study led by Dr. Bermaher here at the University of Pittsburgh. This is a longitudinal study with nearly 400 offspring of over 200 parents diagnosed with bipolar disorder. So of course, we know that bipolar disorder is one of the most heritable psychiatric disorders. And so a major group level risk factor for developing bipolar disorder is having a parent, a biological parent, with the illness. This sample also includes over 250 offspring of 143 matched control parents. So these are parents who do not have bipolar disorder, but can have other psychiatric diagnoses, and some of whom are free from psychiatric diagnoses. On average, we followed the sample for about 10 years, and the parents and their youth were assessed every 2 years over this period. And so what have we learned? Certainly it's no surprise. What you can see here is the rate of onset of bipolar disorder among the two different groups of offspring. In blue, you can see the control offspring, the rate of development of bipolar disorder, bipolar spectrum disorders over time. On the x-axis is age. And so you can see here, not surprisingly, relatively low, what we would expect rates of offspring of control parents developing bipolar disorder over time. Again, supporting the high heritability of bipolar disorder in offspring of parents with bipolar disorder, we see that over 30% of the offspring of bipolar parents go on to develop bipolar disorder themselves by young adulthood. So again, no major surprises here, but what's important to take home is both that the offspring of bipolar parents are at high risk for early onset of bipolar disorder themselves, but clearly not all, and not even the majority of the offspring of bipolar parents go on to develop bipolar disorder themselves. And so this led us to be interested in creating a risk calculator specifically to identify among youth who are the offspring of bipolar parents, who is at highest risk for developing bipolar disorder and when. So in work led by my colleague, Danella Hafman, and our group at CABS, we developed a risk calculator to specifically identify an individual offspring's risk for developing bipolar disorder, given that they have a parent with the illness. And so what you can see here, and the risk calculator is widely available on the internet, is that using this link right here, is that using just a small variety of variables readily assessed in clinical practice, we can enter those scores and yield a risk calculator score for an individual patient in our office to be able to determine their near-term risk for developing bipolar disorder with relatively high specificity and sensitivity. We also have another large sample, again, led by my colleague, Dr. Bermerher, a large multi-site longitudinal study. This is nearly 450 youth, all of whom have been diagnosed with bipolar spectrum disorder in childhood. So at intake to the study, they met full DSM criteria for bipolar 1, 2, or not otherwise specified. We've assessed these youth every 9 months over an average of 13 years. So we have really rich data throughout childhood and on average into young adulthood on these youth's course of illness. And so Dr. Bermerher led one of our risk calculators, the development of one of our risk calculators to try and predict the rate of relapse, the risk of relapse among youth with bipolar disorder. And this is really important because oftentimes when families come into our clinic, you know, a youth may be in the current period of a mood episode, depression, mania, or hypomania, and or they may be coming out of a period of mood symptoms. But what we're really looking to answer is, how likely am I at this point in time to experience a relapse in the near term? And so that's exactly what this risk calculator was built to try and predict for any individual, given where they are in their current course of illness and a variety of historical variables. Can we predict their course? And what we found is that shorter periods of recovery, earlier onset of illness, greater depression severity, and family history of mania were all associated with higher risk for relapse in the near term, again, with relatively high sensitivity and specificity. So we're doing quite well using these risk calculators, much on par with other risk calculators widely used in medicine to try and predict the course of bipolar disorder in youth. Some work that I've been really dedicated to these last couple of years is a risk calculator trying to specifically predict risk for suicidal behavior in youth with bipolar disorder. So we know that youth with bipolar disorder on average are at really high risk for suicidal behavior, as we saw with some of the prior data. However, that really doesn't tell us about who among youth with bipolar disorder is at greatest risk and when. And this is really critical given those longitudinal data we previously saw showing that we are increasing our interventions just prior to suicide attempts, but nothing seems to really be impacting those suicidal behaviors. So the capacity to better predict suicidal behaviors among individuals at greatest risk is critical. And so I'm really excited about these new data. So what we found was that over an average of 13 years, there were almost 250 suicide attempts in our COBY sample among 106 individuals. So almost 30% of the sample over this period of time engaged in suicidal behavior. And what we found is that we were very reliable at being able to predict near-term risk for suicidal behavior. And so given the snapshot in time of this patient in front of us in this moment, we're relatively reliable at predicting risk for suicidal behavior in the near term. So how do we do that? Essentially what we did was look to the literature at common risk factors at the group level. And we put all of these into complex statistical models that I'm happy to talk about in more detail if folks are interested. But essentially what we found is that 10 predictors really accounted for the vast majority of prediction in the model. And what was critical to me is that we chose predictors that are readily assessed in clinical practice. And so these are all variables, more likely than not, that all of us, when we're doing an assessment with a high-risk youth, would be gathering anyway. They don't require specific or expensive tools. These are things like how old were you when your mood disorder onset? Have you engaged in non-suicidal self-injury? How old are you? All variables that we know that are very powerful at predicting near-term risk for suicidal behavior. So what does all of this mean for treatment? Because ultimately that's really the critical nature of risk prediction, being able to identify what we expect in the near term, and then again, mapping on to those clinical staging models. So I want to share with you just a little bit of work that we've been doing, trying to map treatments onto stages of illness in early onset bipolar disorder. So starting at the early clinical stages, so these are the youth for whom we know that they're at high risk, primarily in our case identified by having a parent with bipolar disorder, because we know this is the single most potent predictor of onset of bipolar disorder among youth. And so these are youth who might be asymptomatic, having no symptoms of bipolar disorder, or having some very subthreshold symptoms. They're very early on, but we know that they're at high risk. And so the idea being that potentially we could delay onset of bipolar disorder in these high-risk youth, or potentially even prevent it, which I think is particularly exciting given what we know about the course of illness among youth who go on to develop bipolar disorder. So the focus of the treatments that we've been looking at here is primarily on sleep and social rhythms. So why would we be focused on sleep and social rhythms among youth who are at risk for bipolar disorder? Well, there's a host of literature supporting this direction. The first is that among individuals with bipolar disorder, we know that sleep problems are a prominent symptom of both mania and depression. We also know that sleep problems precede mood episodes in bipolar disorder. So before individuals have a full-blown depressive episode or manic episode, they start to show changes in their sleep. We also know that sleep problems can actually precipitate mood episodes in individuals who are vulnerable. So there are some really classic stories about individuals with bipolar disorder taking transatlantic flights where their sleep has become disturbed and they get off the plane in another country and having symptoms of mania. And indeed, this is because their circadian systems can be very vulnerable. We also know that sleep problems actually precede onset of bipolar disorder in 2 longitudinal studies of offspring of bipolar parents. So indeed, these can be a flag that potentially high-risk youth are going on to develop bipolar disorder themselves. We also know that these offspring of bipolar parents have more sleep disorders than offspring of healthy controls. So their sleep is disordered even before they go on to develop disorders themselves. And in fact, their sleep, even in stages 0 and 1 of this clinical staging model, look more like youth with bipolar disorder than they look like youth who are healthy. We also know that this period of adolescence is a critical time for changes, both biological and psychosocial, in sleep-wake patterns and social routines. So anybody who works with adolescents, has an adolescent at home, or even remembers being an adolescent knows that there are these major changes, both in terms of our school schedules, also in terms of need for sleep, and sleep and circadian patterns, such that sleep tends to become lighter during adolescence, but also circadian patterns tend to shift later, such that adolescents on average tend to want to go to bed later and sleep later, in spite of the fact that our schools, by and large, necessitate them getting up earlier in the morning. And so there's this mismatch between their biology and the psychosocial environment. I'm also really excited by some recent data that I've collected with my colleague Peter Franzen in sleep medicine. And so these data really indicate a strong association between sleep problems and suicide risk in youth with bipolar disorder. And so this was a sample of 33 youth, all diagnosed with bipolar disorder. And in sum, what you can see here, and this is, we assessed sleep using actigraphy, which is just a wrist-worn device, much like a Fitbit, but research grade, that yields data on sleep-wake patterns to give us data on sleep in a more objective way than self-report. And so what you can see here is this very strong association between what we call interdaily sleep stability. And so this is essentially an index of variability in sleep. And so for many adolescents, the variable patterns we tend to see particularly during the school year is going to having to wake up early, preferring to go to bed later, so having sleep debt during the week, but then tending to oversleep significantly on the weekend. And so what you can see here is that the less the youth had stability in their sleep, so more unstable sleep among youth with bipolar disorder was associated with greater symptoms of suicidality using the suicidal ideation questionnaire. So that's this graph on the left. On the right, you can also see a strong association between sleep variability and depression, such that the more variability, the higher the depressive severity. And really critical for me in terms of these findings is this graph on the bottom, showing that actually sleep variability explains substantially more of the variance in suicidal ideation than even depression severity. So generally speaking, we tend to look at depression severity as a marker of risk for suicidality. But in fact, relative to depression, sleep variability among youth with bipolar disorder is actually far more potent at explaining risk for suicidal ideation. So again, really pointing to the critical nature of sleep and circadian rhythms in mood stability and in risk for suicidal behavior. So I was really drawn to a specific treatment called interpersonal and social rhythm therapy. If you're not familiar with it, I'll give you just a brief overview. So this was a treatment developed here at the University of Pittsburgh by Dr. Ellen Frank. And it was originally developed for adults with bipolar disorder. And it's been shown in multiple studies now to prevent or delay illness recurrence and help to regularize social rhythms. So to decrease that variability in sleep that we just talked about among adults with bipolar disorder. And it really targets psychoeducation, teaching families about bipolar disorder, working on regularizing sleep and social rhythms, going to bed about the same time every day, waking up about the same time every day. Also focused on decreasing interpersonal stress that we know can be highly related to sleep difficulties. And then for the purposes of these youth who are offspring of bipolar parents who are at greater risk for developing bipolar disorder, we have a specific interpersonal focus on grieving the lost healthy parent. And so what this is really about is giving these youth an opportunity to talk about what it's been like to grow up with a parent diagnosed with bipolar disorder. And so we recently finished a small randomized trial of youth at risk for bipolar disorder by virtue of having a parent with the illness. We compared youth who received IPSRT, the interpersonal social rhythm therapy, with youth who received what we call data-informed referral. So we did a really thorough assessment with all of these youth to see if they had any psychiatric symptoms or disorders. We referred all of the youth for evidence-based treatment. So for example, some of the youth may have met diagnoses for ADHD or an anxiety disorder. We know that there are other evidence-based treatments for those illnesses. So we made referrals for the youth for those illnesses. And then half of the youth got IPSRT on top of their data-informed referral, and the other half just got data-informed referral. And so what you can see here was really promising to us because, again, these youth do not yet have bipolar disorder. They are at high risk because they have a parent with the illness. And what we found is that the youth who received IPSRT, shown here in red, as compared to the youth who received data-informed referral, shown here in green, had fewer weeks with subthreshold hypomanic symptoms over follow-up. And so this is particularly exciting because in a separate analysis by my colleague David Axelson from our group, he showed that the single biggest predictor of onset of bipolar disorder among youth with a parent with bipolar disorder was subthreshold symptoms of hypomania. And so we can think of this kind of as a potential developmental trajectory from being the offspring of a bipolar parent, developing subthreshold symptoms, and then developing the full threshold diagnosis. And so potentially differences between these two groups in the development of subthreshold hypomania may indicate that we may be successful at either preventing or delaying onset of bipolar disorder and youth at high risk. We also found that sleep continuity improved among the youth who received IPSRT as compared to the youth who received data-informed referral alone. So one of the treatment targets specifically is regularizing these sleep and circadian rhythms. And what we can see here is that indeed we were successful at that from pre-treatment to post-treatment, such that the youth who received IPSRT had less what we call wake after sleep onset in minutes. So their sleep was less disturbed, so to speak, from pre-treatment to post-treatment. Unfortunately, as sometimes happens in relatively small samples, randomization didn't totally work for us. So you can see there were significant differences between the two groups at baseline, but even controlling for that, the IPSRT group improved, whereas the data-informed referral group actually got worse over time. And particularly exciting for us is starting to think about mechanisms of treatment response. And so what we were able to demonstrate in this sample is that those subthreshold hypomanic symptoms that we were seeing at greater rates in the IPSRT group were actually specifically explained by these sleep mechanisms. So the mechanism whereby it looks like we are improving risk or decreasing risk for subthreshold hypomania is actually through improving sleep. So I'm really excited. We've just been funded to do a much larger trial of IPSRT for high-risk adolescents. I know this is a really busy slide, but basically the take-home message here is that in this study, we're actually going to use the risk calculator to select youth who are at particularly high risk by virtue of having a parent with bipolar disorder, with a very similar design to what we've used in the past to try and more definitively determine whether IPSRT may be effective at preventing or delaying bipolar disorder in these youth at very high risk. So stay tuned. We are literally just starting this trial now. And finally, I want to tell you about some work that we've done developing dialectical behavior therapy, which is a more intensive intervention for youth on this end of the clinical staging model. So this is for youth who have already developed bipolar disorder, meet full criteria, have had recurrent illness, and have severe functional impairment. And so in this group particularly, we've been focused on the prevention and treatment of suicidal behavior. If you're not familiar with dialectical behavior therapy or DBT, this is a skills-based treatment that was originally developed out at the University of Washington by Marcia Linehan, specifically for individuals with borderline personality disorder. Although this treatment has been very widely tested among individuals with a host of different psychiatric disorders. And I was really drawn to this particular model of treatment because in adult studies of individuals with with borderline personality disorder, they had shown that DBT was associated with decreases in suicidal behavior, hospitalizations, and substance use, while increasing social adjustment and treatment adherence. So all of these are the same treatment targets that I have been really interested in targeting for youth with bipolar disorder. So in an initial small randomized trial as part of my Career Development Award, where we randomized youth with bipolar disorder between the ages of 12 and 18 to either receive DBT or standard of care here in our CABS clinic, what we found is that youth who received DBT actually attended more therapy sessions over the course of 1 year, which is not really surprising because one of the foci of DBT is actually treatment engagement and treatment adherence, but certainly promising. We also saw in that trial that youth who received DBT exhibited less severe depressive symptoms over follow-up. And so what you can see here is over the course of 12 months, during the period at which youth were either receiving DBT, shown in the red line, or standard of care psychotherapy. So this was essentially any other evidence-based psychotherapy for bipolar disorder, but not DBT. We can see that youth who received DBT significantly showed improvement over 12 months in their depressive symptoms. Whereas youth in the standard of care group had this interesting trajectory where they improved over the first 6 months, but then actually tended to relapse back to similar rates as pre-treatment at the end of the 12-month follow-up period. In our more recent trial, we showed that adolescents who received DBT as compared to standard of care were actually significantly more likely to show improvement in suicidal ideation. Again, what you can see here is that our randomization didn't work so great for us in spite of our best attempts. So actually the youth with DBT had more suicidal ideation at study intake. And showed a substantial improvement at study follow-up, whereas the opposite trend was true for youth who received standard of care psychotherapy. So really highlighting the potential for DBT to target suicidality in youth with bipolar disorder. So I'm super excited because we've just finished a very large randomized trial that has been basically the focus of my work for about 7 years now. So this is following 100 youth with bipolar disorder, randomizing them to either DBT or standard of care psychotherapy. Critically, all of the youth in all of our trials received medication management for the management of their illness as well. We are just analyzing these data now, and so stay tuned for some really exciting outcomes. But we have a host of really fascinating data that will be able to hopefully answer some really critical questions about for whom does this treatment work, when, and why. So we have brain imaging data at baseline and again at 6-month follow-up to look at neural mechanisms underlying improvements with treatment. We're gathering data on sleep and social rhythms at baseline and again over follow-up to try and understand how sleep and circadian rhythms are related to outcome. We have extended follow-up, so we're following these youth over 2 years to see what their treatment response looks like. Are improvements sustained over time? We're working with colleagues in public health to look at cost effectiveness. We know that some of these treatments are very expensive to deliver. We also know that youth with bipolar disorder tend to be really high utilizers. And so in order for us to ensure that these treatments are ultimately implemented and taken up in the community, it also behooves us to be able to demonstrate that while they may cost more in the short run, they're actually cost saving in the long run. Additionally, we have colleagues who are examining some issues related to diversity, equity, and inclusion in the sample. We see very high rates of sexual and gender minority youth in our CABs and STAR clinics, and certainly that's true and represented in this sample of youth with bipolar disorder. And so we are trying to better understand how that interfaces with risk for suicidal behavior in the sample. So to sum up, we know that early onset bipolar disorder is a very severe illness. It's impairing. Certainly we can reliably diagnose it using DSM criteria. We know these youth are at increased risk for negative outcomes and particularly elevated risk for suicide. I've presented and discussed this clinical staging model as a framework for treatment to try and help us better understand for whom do we intervene, at what stage of illness, and using which of these tools to best optimize outcomes for these youth. So in an ideal world, our future would look something like this, where the youth in front of us were able to do a thorough assessment, use some of these clinical tools that don't increase clinician burden to determine where that individual youth is in terms of their clinical staging, not just for bipolar disorder, but for any psychiatric disorder, to better map treatments and potentially better impact long-term outcomes. So with that, I want to thank all of my funding agencies, and certainly it takes armies of people to do all of this kind of work. I have amazing mentors, co-investigators, consultants, study staff, clinic staff, and of course, all of the patients and families who devote their time and energy for us to be able to better understand these illnesses and potentially change outcomes for other families. And I also thank all of you for joining me this morning. So I believe I'm going to turn it back to Molly we have some time for questions.
Yes, thank you, Dr. Goldstein, for that wonderful discussion and super informative about suicidality and especially in our bipolar population. We do have several questions, and before I say some of those, we have in the chat the link for the meet and greet afterward with Dr. Goldstein, if that's something you're interested in. And we will also put in the chat a link for those attending to fill out for a review of how our Grand Rounds is going. The first question I have from the chat for you, Dr. Goldstein, is, are there risk calculators that are developed for other types of diagnoses such as major depressive disorder?
Yeah, so I'm not familiar with any for major depression. Actually, there's one risk calculator for major depression. That is true. There is one for ADHD. There are actually several for early onset psychosis. And so I'm happy to share some of those links as well. I think the really critical thing about these risk calculators is that not all of them have yet been validated in external samples, including our own. And so that's a really critical next step in this kind of risk prediction work. So we know that these risk calculators perform well in our own samples, and that's true for some of these other risk calculators as well. But it's also critical to be able to validate those in other samples. Part of the big challenge in child psychiatry is that we have relatively few longitudinal, well-characterized samples of youth with some of these disorders. And when we do, we don't necessarily have all of the same exact variables measured over time. And so, ourselves and some other groups are working to try and pool data to be able to compare across samples. It's our hope that these risk calculators that perform well, for example, in our COBY sample or our bio sample, would perform similarly well in the community. But that's really a critical future direction for our risk calculators and certainly these other risk calculators as well. What I can say, I think the field that's been furthest along in this area in child psychiatry is high risk for psychosis.
Thank you. And then Rebecca Toback is one of our triple board residents and was kind of thinking along that extension of that and saying, as pediatricians, we frequently start antidepressants for our patients with depression or anxiety. And then should these risk calculators be used in clinical practice as a way to determine risk of inducing mania when starting an antidepressant, or should this risk delay antidepressant initiation?
I'm sorry, I just missed the tail end of that question.
She was saying, should the risk calculated from the calculator be considered in terms of delaying an antidepressant with risk of inducing mania or not, if you're concerned the patient has bipolar disorder?
Yeah, I think it's a really good question. I mean, I think maybe it's still a little premature for that just because the risk calculators haven't been externally validated. But that being said, I think part of what it draws our attention to is some of these risk factors. So like this individual was asking, if you have a youth who's displaying depressive symptoms, who also has a first-degree family history of bipolar disorder, these are some of the factors that you can begin to consider as you're thinking about potential risk. And so again, can we definitively say that, these are reliable in this sample? Yes. More broadly, not quite yet. I think that's absolutely the next step for all of this. And what I think that we can glean from these risk calculators is carefully attending to some of these risk factors that would make it more likely that this particular individual is at greater risk for developing bipolar disorder, given these group level risk factors.
And another question is, what fraction of youth diagnosed with bipolar disorder are diagnosed after a suicide attempt rather than prior to?
Oh, that's such a good question. I cannot say that I know of any data that speak to that question. And I think part of what it gets at is this huge challenge for us in child psychiatry, which is, and particularly challenging for bipolar disorder in youth, because, for some of the youth who go on to develop bipolar disorder, when we evaluate them, they've already exhibited symptoms of mania or hypomania to make it clear that this youth has a diagnosis of bipolar disorder. However, for some youth, their first episode or even multiple episodes are major depression. And it's not until later on in the course of their illness that they go on to develop symptoms of hypomania and mania. And so, we may be treating them for depression, whereas, what ends up unfolding over time is in fact that they have a vulnerability to bipolar disorder. So I think that's part of what makes all of this so challenging. The other part that I think is challenging for that specific question is that, in general in the community, again, we see this overdiagnosis and underdiagnosis. So the reliability of diagnoses of bipolar disorder strictly from electronic medical record data is relatively low. So, it's kind of hard to make conclusions based on those data, but I think that would be a really fascinating study. Certainly we know that some youth diagnosed with depression, exhibit a suicide attempt, go on to develop bipolar disorder. Some youth who are diagnosed with depression actually have bipolar disorder. We've, for whatever reasons, been unclear about the diagnosis, then have suicidal behavior later. So I think those trajectories are still somewhat unclear. Some of those we'd be able to get at in our bio sample, but relatively speaking, the percentage of youth who are offspring of bipolar parents who go on to develop bipolar disorder, who also exhibit suicide attempts, even though it's a really large sample, is still not quite enough for us to get at that question. But I think these are critical considerations clinically as we're treating these high-risk youth.
Thank you. And we still have several more questions, but as we're approaching the 9 o'clock hour, I would encourage us to all go over to that next discussion. We can continue to have the wonderful discussion we're having currently. Thank you everyone for joining us, and thank you again, Dr. Goldstein, for that wonderful presentation.
Thank you so much for having me.